Okay, welcome everybody. This video will talk about the non-stress test during pregnancy. Now I looked online and there really isn't too much information out there, so that's why I wanted to make this video. This is a good tool for both patients to understand what the non-stress test is and for students on the application and how to interpret the results. So what is the non-stress test? Well, it's a screening tool used by a big fancy machine that I have a picture of it later coming up. But what it is it's used to assess the fetus's acid-base status and how it oxygenates. So what we're going to be doing is we're going to be using some skin probes, meaning we're not actually going to go through the skin, we're just going to place some probes on top of the skin, one for the uterus and one for the fetal heart rate. And we may also give the mother a little button that she can click, and I'll talk about that in a little bit. But what we'll be measuring is measuring the uterine contraction, so when the uterus actually contracts. And then also we'll talk about fetal heart rate as well. We do monitor that and then compare the two. And then lastly, there's a subjective factor. If you give the mother a button for the machine that she pushes every time she feels the baby move. So not all baby movements mother feels, but that's just another option that you can throw in. So here's the machine that uses, here's a printout. Here's the sample printout, and we'll be covering that in pretty good detail coming up, so don't worry about that too much. Now, for imagination's sake, here's the printout that we just saw. Here's a sample result. Now, I want to just orient you right now, what are we looking at? And then we'll go over the details, so don't actually look at the line yet, but I'll be talking about what A, B, C, and D actually are. So everything below my cursor right here, everything on this bottom part of the printout is going to be measuring uterine contractions. So this line right here is going to be measuring our uterus contractions. Now right here is going to be kind of a little uptick. Here's when the uterus actually contracts. Here's a little bigger one looking at it. Now one thing of note, the amplitude really doesn't matter, and I say that because in a really obese person, they have a lot of fat between the probe monitor and the uterus. So the contractions of the uterus really aren't picked up as well. So the contraction of the uterus happens, and it really has to go through a lot of fat and tissues to reach the probe, so you won't get as big of an uptick. Conversely, on the other hand, a really skinny person may have a small uterus contraction, but really there's not much tissue to go through for the signal to go through, so it may appear as a large blip. So really what we are just looking for is we're looking for any uptick, which will show that the uterus contracts, and that contraction then will go up here and compare it. But so this is just going to be the uterus contraction. C is going to be, all these little black lines are going to be fetal movements. So when the black line happens, the machine picks up a fetal movement. So the larger black lines here are going to be a larger fetal movement. Now, point B is going to be the mother pushing the button when she feels the fetus move. So if she feels a kick, she'll push the button, it'll make a little notch, and that kind of correlates to this larger fetal movement. So yeah, the mom might have felt that. These smaller ones, the mom doesn't always feel all the movements, but the machine will pick them up. And then lastly, we've got point A. Now point A is going to be the fetal heart rate. And the fetal heart rate is going to be measured. See this just to the left of my cursor here is at 200, 180, 160, 140, 120, blah, 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 blah. What we're looking at is the baseline of the fetal heart rate. And then you'll also see these upticks. You really don't see any downticks, but a downtick would kind of be a little trough just like that. And I will talk about that in a little bit. But right now, just appreciate that you can see kind of a baseline. Even after the uptick, it'll return to a baseline. Over the long run, each one of these boxes, so right here to right here, is going to be, maybe I can get a pen. Here we go. Right here, right there, right there. That's a minute. Now I made my own little kind of graph that we can draw all over when I'm explaining these things, but just realize that we're determining the baseline over the long run. You don't determine the baseline from minute to minute, you determine the baseline over a series of time, not just a minute. Alright, So as promised, here is my sample that we'll be using. Same principles. Here's the uterus contraction down here, and then we'll be measuring the fetal heart rate up here. All right. So what are we looking for? I always use the same system when looking at a non-stress test printout. And I say this because there's a lot of information initially presented with. Now, I always start by finding the fetal heart rate baseline. Here's a fancy explanation of what that means. However, I just like to think over the long run, you will get baseline variability, meaning the baseline shouldn't always be 140, for example. Maybe it'll bump up to 145, maybe it'll go down to 130, but really you'll see kind of a change over time. Now, if there's no variability, so if it stays at 140 for a period of 3 hours, you may be a little worried because you'll see absent baseline variability. If you do see variability, it is normal, but absent, this is not always the best. Normal heart rate is between 110 and 160. So a fetal heart rate of 110 shouldn't throw any red flags, but if you start dipping below 110, you'll get fetal bradycardia, and that maybe will be cause for concern, but we'll talk about that in a little bit. So there's 4 different measurements of baseline variability. So to demonstrate these, I want to draw here. Now, I'm not an artist. I'm in medicine for a reason, but absent variability, there will be 0 baseline variability. Now, this line right here is going to be a 140 heart rate. So if a fetal heart rate, just imagine a straight line. My pen's not going to allow me to draw a completely straight line. But if I saw this tracing right here, and you may see tiny little kind of waveform changes from second to second, but over the long run, so each of these are a minute, so we're looking at a period of, 18, 19 minutes. If I saw this tracing, I would express real concern because it's absent variability. Variability is a good thing. So if I saw absent variability, meaning there's 0 beats per minute change in that baseline over the long run, then that's not the best. So let's clear this and move to minimal variability. If I can get there. Okay, minimal variability. Minimal variability is going to be less than 5 beats per minute. Now, less than 5 beats per minute, again, I'm just going to set an arbitrary 140 value. And our baseline may go up for a little bit, may go down for a little bit, may hover at 140, may go back down a little bit, maybe go up to 145. There you go. This would be demonstrating minimal variability, assuming that if this box was 140, this was 150, you can kind of eyeball it. Halfway between the two would be approximately 5 beats per minute. So as long as we stay within 5 or less beats per minute variability, I would consider that a minimal variability in fetal heart rate baseline. Likewise, we'll move on to moderate variability. Now, moderate variability is anywhere from 6 beats per minute all the way up to 25 beats per minute. Now, moderate variability is what you'll pretty commonly see because baseline really doesn't stay the same. So again, we're going to use 140. Maybe our baseline is going to go up to 160. Maybe it'll go back down to 140. Maybe it'll go kind of down a little. But over the long run, you're kind of hovering around that 140 mark. Really, our beats per minute don't fluctuate too much, and we're not going off the graph paper, but you're able to see kind of the progression. For the first 5 minutes or so, we're slowly increasing the baseline, but maybe later on, the baseline may normalize, so over the long run, our baseline is changing. All right, let's clear this. And then lastly, marked variability is going to be 25 or more beats per minute. Now this is This is a little concerning because it would demonstrate kind of like this, where these changes are not just decelerations and accelerations. These are actually the baseline changing. Now, I can't really show this over such a short period of time, but the baseline, so maybe that's continued over, the baseline is changing pretty significantly. Now, this is not just not an acceleration because it's happening over a period of 15 seconds or 15 minutes or so. So that wouldn't technically be an acceleration. This would be baseline variability. Okay, so let's move on. I think I gotta clear that. Alright, so I threw out some terms, accelerations and decelerations. Now I want to kind of go into what they mean. We just talked about baseline. Baseline is for the long run. Now there's that definition that I gave. That's all fine and dandy, but really you can eyeball baseline. Accelerations and decelerations are another thing that you can kind of eyeball. Now, they're based on two groups, one that occurs before 32 weeks and one that occurs after 32 weeks. So before 32 weeks, an acceleration would be 10 or more beats per minute increase in fetal heart rate. So if we're at 140 right here, it'd be increasing up to 150, 155, somewhere up there for 10 or more seconds. So remember, each one of those lines was a minute. So we're just talking for at least a little bit of time. That returns to baseline within 2 minutes. So if there's another minute box, so 1 minute, 2 minutes, our acceleration would go back down to baseline. Then we'd finish off baseline for a bit. So this would be technically an acceleration. We have a fetal heart rate increase, but it returns back to baseline. Now our baseline may be slightly variable, so our baseline might have changed slightly in that time, but we're approximately 140, we're going to be approximately 140. That's the definition of an acceleration prior to 32 weeks. Now the only difference between after 32 weeks is going to be a greater acceleration for a little bit longer period of time, but yet still returns to baseline within 2 minutes. This is indicative of a healthy child. These fetal heart rate accelerations are normal. It means the acid-base status of your child is going to be normal. You're confident that the acid-base status will be more normal. Okay, so that's accelerations. Let me draw in an acceleration here. I kind of free-handed it otherwise, but we're gonna say our baseline is 140 right there. So we've got our baseline, and then there's 1. Here's 2. Okay, so what did I just draw? This one right here, you can tell that our baseline is 140, and it went up to about 155. So going up one line is 10, and a half is 5. So it went up about 15 beats per minute. Remember, this is fetal heart rate, so fetal heart rate, and then each one of these is a minute. So this acceleration began at minute 0, or at time 0, and by time 2 minutes, we were back at baseline. So that met that requirement. It went up at least 15 beats per minute. So that would meet the requirements for both before 32 weeks and after 32 weeks in reality. And so that would be an acceleration. We returned back to midline. And it lasted for more than 10 seconds. Each one of these is going to be a minute. This would be over a period of almost 60 seconds, and then return back to normal another 60 seconds. That's definitely more than 10 or 15 seconds. This one, it's going to have a greater increase, but really it's going to be the same thing. It's more than 10 or 15 beats per minute for a longer period than 10, 15 seconds. This one, on the other hand, here's our time 0, here's our baseline. It's going to accelerate at a slower rate and return back to normal. This would indicate more of a baseline variability. Now, on how I drew this is a minute, this is a minute, this is a minute. Not all labels are the same, so be sure to check on what your tracing is showing you for the time. However, for my time tracing, this is going to be more of a baseline variability because its acceleration, it is increasing by more than 10 or 15 beats per minute. However, it's not returning back to normal in 2 minutes, and also over the period of longer time makes you think baseline variability. Alright, so that is everything you should kind of basically know about accelerations. Decelerations, on the other hand, are not good. So accelerations are good, decelerations are not as good. These are based on uterine contractions as well. So the accelerations, let me go back. Let me find it here. Okay. So we have our acceleration there, acceleration there, acceleration there. These may or may not compare to our uterus. So if our uterine contraction is there, maybe it's there, and maybe it's there. If our uterus is contracting, as our acceleration happens, maybe these should have been lined up a little better, but as the uterus is contracting, sometimes the fetus heart rate can increase. This would be an early acceleration. Now a late acceleration, we see our uterus contracting at this time, right here. Now, a minute or so later, I don't think I drew this as good as I could, but shortly after that uterus contraction, then we may see the onset of the acceleration, with the peak occurring not in congruence with the uterine contraction. So that would be considered a late acceleration. Well, this would be considered an early acceleration. Early meaning that the peak and the uterus contraction would occur at approximately the same time. A late would be a delayed fetal response heart rate. And then this one would be an early as well. Okay, now let's move on to decelerations. So for a deceleration, it's not good. So we have 3 different forms. We have the late, we have the early. So that's exactly what we were just talking about. Slowly occurs after uterine contraction. So here's our uterine contraction. We would have, here's our uterine contraction. Here's our baseline. We would see that deceleration slowly and back to normal. An early deceleration would be, here's our uterine contraction, baseline, trough, baseline. So the nadir, or the lowest point of the deceleration, and the peak of the contraction are both kind of lined up in the same time. And then lastly, variable, what you'll see is you'll see an abrupt decline in fetal heart rate. So there's our uterus contracting. I guess, here, let me draw it on, what am I thinking? Here we go. Instead of trying to squeeze it all in there, let's demonstrate what this is. So we have a late deceleration. Now here's, I guess I should draw it at 0. We're going to see a uterine contraction and a uterine contraction. For a late deceleration, our baseline is going to be 140, 140, 140. There we go. Notice how we have our uterus contraction at this time, and shortly thereafter we see the deceleration, the peak of the deceleration, and it slowly returns back to normal. It's not an abrupt change, it's a very slow change, and it'll slowly return back to baseline. So we'll see it again here. Here's our uterus contraction at this time. Our fetal heart rate dips down to the nadir, and then returns back to baseline. Let's go to an early deceleration. Now an early deceleration is going to be similar. I already kind of drew it out, but what we're going to have is you're going to have a uterus contraction. That's good. 140 baseline, you'll see kind of the nadir line up with the uterus contraction. So here at the same time, approximately the same time, you'll have the lowest point or the trough lining up with the highest point of the uterine contraction. That would be an early deceleration. Then lastly, we have variable. So let's draw in variable. Here's our uterine contraction, uterine contraction. Here's going to be our baseline. All of it, I mean, it's a very steep, very sudden deceleration. While the other ones were nice and slow, and you'd see the nadir, this one, you're pretty much going to reach the nadir right away. It's a very kind of ominous, non-reassuring sign. So that would be a variable deceleration, where you'd see that really rapid onset. Alright, so, oops, let me get that cleared off really quick. Okay, so here's the categorical findings. So we just kind of interpreted it, but now we have to categorize it. So there's going to be three main categories that we're going to be using. There's going to be category 1, category 2, and then category 3. Category 2 is kind of the trash can. We're going to see if it fits in 1. If it doesn't fit in 1, we're going to see if it fits in 3. If it doesn't fit in 3, we'll throw it in 2. 2 is kind of the trash can category, meaning it's not good, it's not bad, we don't know at this point. We need maybe a little bit more monitoring of the fetus. We don't know if its acid-base status is perfect, we don't know if it's horrible, we still need to check it. So if you see a category 1 fetal heart rate tracing on a non-stress test, it indicates the good acid-base status. A 3 is negative, meaning we may have a more poor acid-base status of the fetus, so we need to do additional testing. And then 2 is kind of non-determinate. Alright, so let's talk about a category 1 result. Category 1 result occurs when you get the fetal baseline within 110 to 160, so that's what most of the baselines are. Accelerations can be present or absent. Accelerations present are always reassuring, however, you do not need it to have a reassuring finding. Baseline variability. This is going to be an important one. So we already talked about the baseline variability. The moderate reading was anywhere from between 6 and 25 beats per minute. So a variable baseline over a period of time is a reassuring sign. And then also no late or variable decelerations. Let's see. Then we go to 3. So if it didn't fit in 1, now I always go to 3. Does it fit in 3? A sinusoidal heart rate baseline. I didn't talk about it because I don't see it very often, but a sine wave is just like that. It's just a repeating segment. So for maybe a couple minutes it'll trough, maybe for a couple minutes it'll peak, maybe for a couple minutes. But if it does this, if it recurs over a period of time where you get this peak for a couple minutes, this trough for a couple minutes, that's going to be a sinusoidal heart rate baseline, and that's not always the most reassuring baseline expression. Also, if you have absent baseline variability, meaning there's 0 baseline variability, it's not good. And then also minimal, remember less than 5, not always the most reassuring either, but it does at least show some variability. So that's a little more acceptable. The fetal heart rate below 110, so if you have a fetal bradycardia, that'll set you into category 3, meaning your acid-base status of the fetus is may not be the best. And then lastly, you have the recurrent or late variable decelerations, which we talked about in 1. If 1 they didn't have it, then it would be a 1. If they do have it, it would be a 3. And then, like I said, 2 is the trash can. So if it doesn't fall within 1 and 3, then it'll be a 2. It'll be kind of the gray area in the middle, because there could be a lot of expressions, but this is just one of the categories that is chosen. The very last part of our discussion is going to be a reactive versus a non-reactive stress test. Now just remember that reactive is good and non-reactive is bad. So for a stress test to be categorized as a reactive stress test, you need to see at least 2 or more accelerations over a 20-minute span. Now a non-reactive stress test would be less than 2 accelerations over a span of 20 minutes while being monitored over 40 minutes total. So that would be considered a non-reactive stress test. Now if the non-stress test is reactive, that's good. You probably don't need to do much more monitoring unless if there's indications for it. However, if the stress test is non-reactive, you may need to do some further testing just to make sure that the acid-base status of that child, make sure that child is developing normally. So here's my works cited. If you have any questions, be sure to ask. I know that this wasn't the most comprehensive, but it should be a good introduction to the non-stress test during pregnancy. I tried to touch on the main kind of academic points. Once you get into the clinics and actually see a real result, hopefully this will allow you to be more competent in interpreting the results. But really there will be a lot of clinical variation. Not everything looks perfect as it does on paper. So again, if you have any questions, be sure to ask. Otherwise, like and subscribe. Thank you very much.